My name is Jackie Christensen. I'm a nurse practitioner who is currently contracting in New York City to help with patient care and management during the pandemic. I've been in emergency services for about 13 years now, and I have worked as an EMT, an ED tech, and as an RN prior to becoming an NP. So hopefully this information in the presentation will be helpful to you all as we navigate this course together. Objectives are as listed on the PowerPoint slide. The overarching goal of all this is to give you the knowledge and practice recommendations both to keep yourselves safe during this pandemic and to help as many patients as you possibly can, and just understand some of the practice changes for COVID-19 patients specifically compared to our other normal guidelines such as sepsis guidelines. COVID-19 is a viral disease that's multifaceted and affects many systems. It has a variety of names, including just the coronavirus. It's also called SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome, of which this current coronavirus is the second iteration. Symptoms of COVID-19 have a whole variety of symptoms. They can include, throughout the various course of illness, respiratory symptoms like hypoxia, difficulty breathing, and respiratory distress, cardiovascular symptoms like chest pain, constitutional symptoms like fever, general malaise, fatigue, and body aches, and GI symptoms like abdominal pain or diarrhea. And many patients can actually be completely asymptomatic or minimally symptomatic. So that's something to keep in the back of your head too, that even somebody who's not necessarily presenting with these symptoms may in fact actually have COVID and they're simply asymptomatic from it. Something else to consider is that a lot of COVID-19 patients' symptoms evolve over time. So they may start out with abdominal pain or diarrhea that goes away after a few days, but they then eventually develop some of the respiratory symptoms or some of the constitutional symptoms like fever. Another thing I'd like to point out is that the hypoxia that comes with respiratory symptoms are not necessarily always, they're not always associated with shortness of breath. We're seeing a lot of patients come in right now who have hypoxia, but aren't reporting any shortness of breath or any cough or any exertional dyspnea whatsoever until they become more severely ill. So hypoxia by itself can actually be one of the warning signs that COVID-19 is what you're dealing with. So keep that in the back of your head as well. Best evidence seems to suggest droplet, contact, and airborne spread of COVID-19. While the airborne route is still being investigated, some recent studies do actually show detectable virus counts in exhaled air without coughing or sneezing, which is a likely indicator that this virus is transmitted via the airborne route as well as droplet or contact. Droplet and contact have definitely been more definitively established, and there's still more ongoing research to confirm that airborne spread of COVID-19 is indeed happening. At the time of this taping on April 11th of 2020, worldwide there were 1.7 million confirmed cases, 500,000 of which were in the United States alone. Of these confirmed cases, worldwide there have been 100,000 deaths, with 18,000 of those in the United States, and worldwide 400,000 cases have been confirmed as recovered. Note the earlier use of the word confirmed. Due to testing shortages and a high false negative rate for the nasopharyngeal testing route, which we'll talk about in a little while, the number of confirmed cases is actually very unlikely to reflect the actual number of confirmed cases, and indeed the actual number of deaths due to complications of COVID-19. Out in New York City, a lot of our critically ill patients actually died before their COVID-19 test resulted, or even before the test was collected. And many patient deaths are actually called in the field by emergency medical services and paramedics before they make it to the hospital, which means we're almost certainly underreporting the number dead from this virus as well. Additionally, the nasopharyngeal test has a very high false negative rate, as I mentioned just a few minutes ago. Anywhere between 20 and 50% is the false negative rate, depending upon how long the patient has been sick for and how the test was collected. The nasopharyngeal route is usually collected by putting a swab all the way back into their nasopharynx via their nose, not just a nasal swab like we've been doing for influenza. So just a simple nasal swab where you only swab the nair itself will often get a false negative, where a proper nasopharyngeal will not. It also depends on how long they've been sick for. We've been seeing patients with more false negatives that have been ill for the 10 to 14 day mark compared to patients who have only been ill and likely have fewer severe symptoms in the first week or so of illness. So keep that in mind. The rate at which the nasopharyngeal swab comes back positive it's a good way to confirm that yes, it's what they have, but it's not a good way to say, no, this definitely isn't what they have, just because the likelihood of having a false negative is so high. Also, keep in mind that to the best of our current knowledge, there's a 4% critical illness rate and roughly a 1 to 2% death rate when adequate health resources are present. As you might guess with that, that death rate really does increase markedly if there are no available healthcare resources to care with the critically ill. And if the resources aren't available, the critically ill rate frequently can very quickly become the death rate. Finally, emerging research does seem to indicate that COVID-19 might be mutating. It's unclear if the different suspected strains that have been found can cause a new illness in somebody who's recovered from previous COVID-19 infection. However, mutation and reinfection with a new strain is definitely still within the realms of possibility. So it is possible, within the theoretical idea at least, that these patients could have COVID, get better, get reinfected with a different strain. We don't yet have enough research on that, and the research on the new strains existing by themselves is actually fairly new. So there will be a lot of evolving information on that coming out as the next couple months go by. So this comic just demonstrates the difference between droplet and airborne routes as far as routes of infection go. The left side shows the droplet route, in which somebody's exposed via direct coughing or sneezing that causes expulsion of droplets, where the airborne route is a route in which just inhaling the same air as a diseased person exhales can actually expose you to infection. Similar in nature to tuberculosis. So tuberculosis is a well-known airborne spread disease. Tuberculosis is the right. Influenza is a common droplet spread illness that's not airborne. Influenza is more the comic on the left. Bear in mind that this is part of why 6 feet of social distancing is recommended. 6 feet of space between you and an infected person, even with an airborne route, does significantly decrease the likelihood of your airborne exposure because exhaled air doesn't really, first of all, it doesn't remain infectious indefinitely. And second of all, with a 6-foot radius between you and the sick person, there's a lot more room for that air that they've expelled to diffuse before you breathe it in. So that's why there's a 6-foot recommendation, despite some sources thinking that this is just a droplet spread only disease.